Good afternoon, innovators. David Wright here, and I'm your host of the Disruptive Innovators podcast, coming to you live from Dean Street Studios in Soho in London, or good morning, depending on where you're tuning in from. And today, I am lucky enough to be joined by my friend Tim Caroe. Tim, pleasure to have you.
It's a real pleasure to be here today. Thanks.
Yeah, I'm glad it lined up. Tim, for any of our listeners who may not be familiar with you, your work, or your current role, would you mind just doing a brief introduction?
Sure. And funnily enough, I got a prize for this at the conference that I was at, to have the longest title, when they introduce everyone.
Yeah.
And they go, hi, you do this, and Tim. So my title, so I'm a GP in Eastbourne.
Right.
So for those guys in the States, that's like family doctor. So I do that every week. I work in the southeast region of England. So there I'm the medical director for primary care and the acting CCIO, which is to do with kind of clinical safety and other stuff. And then nationally, I have a role in the primary care medical directorate, and I lead that for digital and data. So basically by that time, the audience had either fallen asleep or they were there. So yeah, that's a long title. So I hope that's interesting for your listeners.
It is. I mean, it's a lot of different vantage points, which is one of the reasons I was interested in having you. Tim, I like to start every episode with, if there was only one, and I'm sure there will be plenty given your experience, but one piece of actionable advice you might look to leave folks with today. What might that be?
Oh, that's a good one. It might sound a little bit trite, but just sort of bear with me. And it's something about being true to yourself, being true to yourself. And the reason I say that is often we're looking at, what are other people thinking about what we're doing, and we're doing it for them. We're doing it for, because we have to, because we feel we need to. The one thing that I felt I've done in my career is to do the thing in front of me just to the best of my ability, without thinking I'm doing this because it's going to take me, and blah, blah, blah. Just being true to yourself in that moment and doing the best that you can. And as you do that, your integrity and your honesty shines through.
No.
And that feels important to me.
I mean, that doesn't seem trite to me at all. And I've found that, because it seems it's business oriented in that, doing whatever it is that is authentic or true to you, you could do as an occupation, and just being true to me, myself. I'll just say that my biggest strides in business have been tied to, things like that, which are personal development related too,
Yeah.
And the more that I've focused on just what's in front of me and not projecting into the future or living the past or thinking about, like you're saying, trying to conform to what I think someone wants, I've found a lot of joy in that.
Yeah, absolutely. And I think one of the key things at the moment is like sustainability, and everything just sort of comes at you, and it's really hard. And if you're doing something that doesn't really chime to what's important at the heart of you, then actually that's a real recipe for difficulty. You can manage it in good times and you're like, but when the pressure comes on,
right,
that reveals what are your motivations, why are you doing that? And if you're doing it because it is part of who you are, then that's what shines through. That's what gets you through. And that's what a leader is. That's people are looking to you going, hang on, other people around you are sort of like stressed and falling. And yet, you seem to still be in that space.
Right.
And so people recognize that.
Yeah. No, I mean, that's been true for me, because I've never been busier in my life than I am in this moment right now. Children, houses, business-wise, I'm here right now, right? But I love the work that I do.
Yeah.
And I get a lot of joy from it. And earlier in my career, I remember being so far up my own asshole, just in regard to, I'm so busy, like, oh my gosh. And it was just, it resonates, just doing things for the wrong reasons. Because at the time in my life, it was very much about me and my ego and getting this thing that was going to make me okay. And now it's very much about how am I leaving an impact on society? You know, what am I doing that's going to affect the way patients access care or receive care? How am I being the best father, the best partner I can be? Things of that nature, you know?
Totally. Yeah.
So great, I think a great piece of advice to start the episode. So Tim, let's talk a little bit about your origin story. So, I mean, you mentioned your title. I've accumulated at least a few over the years, but how did you start out? You know, did you always want to be a doctor, and how did you kind of get to the point that you're at in your career today?
So my dad is a doctor, so that you might say sort of a lack of creativity kind of got me here. But when I was going through school, I wanted to go to Cambridge. That was kind of like my big thing. And people say, well, what are you going to read? I was like, books. I go, no, that's not what I mean. What are you gonna study? And I'm like, oh, that's a good point, because I kind of just want to punt and, you know, do stuff. And I got to read something. I've got to do something while I'm there. And in Cambridge, for, you know, reasons of technical stuff, medicine it gives you kind of various options. You don't have to go down the medical route. There's all sorts of other things you could do.
And just quickly, for those of our listeners who do not know what punting is, because I didn't, it's you do it in both.
You have a big pole and you just kind of push down the river.
It's lovely.
Google it.
Google. Continue.
Oh, it's super fun. And I just kind of lucked out really of the thing that I, you know, just chose to do. I absolutely loved. And then it's been, you talk about being true to yourself. The thing about me is I just find that making a difference and supporting people really, you know, gives me pleasure and gives me joy and sustainable. So as I was then sort of learning more about medicine and, you know, supporting people, and I just got so curious about it and how can we do it better? And it was that sort of curiosity and that desire to kind of be pushing the boundaries a bit. And if that happens a little bit every day, like that 1% theory, you know, you end up as national medical director for you know, stuff. So that's kind of been that trajectory. So, you know, that other piece about be curious about the thing that doesn't quite work.
Mm-hmm.
Why doesn't it quite work?
Yeah.
What could we do? What's the, and it's if you're curious about that thing, then you suddenly become in an ecosphere of, oh, actually that thing, this is how we could change it. This is how we could do things differently.
Yeah.
And one of the super things about being a doctor here in the UK, and I don't know how that influences, how that maps over to the States, is that we have a network of independent businesses.
Right.
So fundamentally, we haven't changed much since 1948, since, you know, the start of the NHS. And each primary care unit is its own business. So you have a huge amount of autonomy about how you manage things. And that can be really great. Sometimes it can be not so great. But anyway, it does mean that curiosity can lead you to really interesting places.
Sure. I love the curiosity bit, because for me, curiosity in and of itself implies a level of humility. Basically, that I want to be a lifelong learner and that I want to continue seeking, as opposed to being so staunch in just knowing, right? I just think it's a quality of a great leader, really.
Absolutely. And if you think about the opposite, when people are no longer curious, you see it.
Yeah.
You go, well, why does this happen? Well, that's the way that we need to do it. And,
right.
But hang on, if we're going to, no, you see that lack of curiosity. And though it's difficult then to follow, to be a good follower.
Yeah.
Being a good leader, being a good follower. It's hard to follow someone, I think, who isn't curious.
Yeah. I do appreciate too, my experience of physicians in the UK and the dynamics between nurses and physicians, and like I've met a lot of humble physicians in the UK. I don't know if that's just those I've come in contact with or what, but I just, I've really appreciated like the come from many of them, right? Which is not that, and I'm not going to speak to the US because I have a lot of friends that are physicians. And most of the ones that I know in the US, this isn't true, but classically, physicians often get accused of that like God complex,
Yeah.
And meanwhile, in the UK, my very rudimentary understanding is like, as physicians are coming up, they actually work a lot with the nurses in a leadership position, and they often take, not necessarily direction from nurses, but like there's, as opposed to in the States, sometimes there's this dynamic of nurses are, especially like nurses that are doing rounds and like, they're almost like, everybody's like, oh, we appreciate nurses so much. But then sometimes there's this view of them being like, yes, but also like, I need this from you, right?
Well, it's really interesting. You should reflect on that, because organizations can have very different cultures off the back of it. And I think primary care in general, you get trained in a hospital, then you have to like actively leave the hospital to get into general practice, family practice. So you're kind of leaving what can be quite a hierarchical organization to go into generally, again, what's been small businesses. And if you're working in a small business and your receptionist goes off sick, you're like, well, who's going to answer the phone? Who's going to sit at the front desk? Your business collapses. So you very quickly garner that level of respect for every member of the team.
Love that.
If you have a godlike complex, just, make it so who's going to unlock the front door. You can be a god in your own room and there's no one there.
Right.
Do you know what I mean? So there's a continual respect of each other's expertise, which we all pitch together. And I think that's exacerbated and encouraged by the new way of which we're working. So in the old days, you had to see a doctor. But if you come to my practice, you might see a doctor, you might see a nurse, you might see a physio, you might see a mental health professional. There's all sorts of different people, a social prescriber. We're all pitching together as a team to deliver the care for that individual. And I know that my physio can manage that painful shoulder better than I can. So as soon as you start getting above your pitch, someone's going to come along and know stuff that you don't. So I think there's an inherent level of humility working with a team.
Do you translate pitch for our listeners?
You come in, I can't remember the context that I said. That,
above your pitch.
Oh yeah. As soon as you start thinking, oh, I'm God's gift to this.
Right. But the pitch is on the soccer field. The football field.
Let's well, I don't know whether it comes as a baseball. We'll have to look that up. That's going to be their homework.
Yes. So what would you say, Tim, along the course of this journey that you just described, from kind of starting out at Cambridge, which is a super cool place, and then to today, one of the most important things that you learned over the course of your journey?
Oh, wow. Apart from humility, curiosity, and being true to yourself, I think there's also an element of just being restless, being just dissatisfied enough with the status quo. Because it's easy to get comfortable. And you kind of go and you sit there and you're like, well, where's things going to take me? And you just sort of carry on. But there's this like restlessness of, where can we do this? So in terms of my journey, I start off in a hospital, just big team looking after lots and lots of people. And I'm thinking, how have they got here? How did they get in this state? What's happening outside of these walls? And some of the people that I met who were working as GPs just seemed to ask the right kind of questions about, like, how did you get here? And like, they saw people holistically.
Right.
I was working, in cardiology, and, they're like cardiology, there's a heart, and then there's like a body around it that you have to deal with as well. But you're only interested kind of in that heart bit. I was like, I'm interested in that whole person. So that was the journey from like organ to person. Right. And then when you get in there and you're like, with the person, you're like, but person's in a family. And then so you go from like episodic doctor to wanting to be in one place to get to know a family. And then you go, but that family's influenced by this. And as you do that, your vision gets bigger and bigger and bigger.
Right.
And that's what's always led me to kind of more leadership roles and more thinking about trying to influence that bigger context of people.
Yeah. And I don't want to jump the gun. I am excited to talk to you about the INTs and, the implications of that, because one of the things that I've been so impressed with in learning about the NHS and what you guys do is the emphasis on community care and behavioral health and, sending people into the home and the implications of that. And so it's great to hear that even as a GP, that's where your mind is at. And obviously, I think you have a unique, again, vantage point per your greater role. All the same, I think it's a focus of a lot of folks in the NHS. And that's not to say that a health system in the United States doesn't have a similar well-roundedness necessarily, but you don't see like people coming into the home. I mean, my partner gives birth. They're not sending a nurse out a week or so later, right? So we'll talk more about that. I did want to ask, was there a time in your journey that you either had a project fail or there was a personal hardship or, anything like that, but you ultimately took away a profound lesson, like there was a moment that you can think like, oh yeah, I really shifted at that point in my life or my career or something like that?
Yeah, totally. So COVID. So they were really, really tough times for a lot of people. So I became chief medical officer for Sussex, and Sussex is one of the counties here. And I joined, and 10 days later, the CEO came into the room. He said, by the way, we've just been designated as the epicenter for Europe for COVID. So I'm kind of like sitting in a room with everyone. We're looking at each other going, I won't swear, but you can imagine the kind of reflections of us all going, wow, what does this mean? And the pressure that we're all experiencing at that point. And, from that time, you're getting emails at 2 a.m, 4 a.m, the pressure, really feeling that. And I remember someone coming to me saying, Tim, I think there's something going on here about a disproportionate impact on people of color and people in different, it's not affecting everyone the same. And I was like, okay, right. And I could have gone, let's book a meeting. Let's kind of do something. I'm so busy. I think that's important, but let's follow it up. And actually just kind of going, okay, I'm just going to clear my diary. I'm going to sit and listen to you. And there was that point that I said, we've got to do something about this. So from a point of like just exhaustion and feeling like, is this going to break me? Making sure that you again stay to that true north. And when that kind of person comes in, goes, there's something happening here. Inequalities and disproportionate impacts. And, as things turned out, that was absolutely the case. And, there was big national stuff and evidence, and we know that sadly people were disproportionately affected. In Sussex, we got on top of that really early. I put something in place that helped to support people. We were first to look at identifying people from certain postcodes who had certain deprivation so that we were targeting those people who needed to be done. And yeah, there was an independent review said that we saved lives.
Wow.
So there was a point of, is this going to break me? And am I going to be listening to the right people? But, when it came to it, we were able to stop and listen and then take action. And, that was, I took away from that real being true, being curious, being honest. And yeah, we saved some lives that day.
It's massive. Massive. So I want to talk more about kind of your outlook on the future of healthcare and the NHS. And no, you don't have a crystal ball, but do have a couple questions. Before that, I always do like to ask favorite book or literary piece, either that you've read recently, historically, your choice.
Oh, that's a great question. I'm going to go with the Foundation series by Asimov. And the reason I do that is that was such an influence in my youth. Sort of this big like space opera. It's got AI in it.
Yeah.
And it's got that sense that humans can be supported and augmented through the use of artificial intelligence, and they can be guided, and that was really revolutionary. Obviously, he's writing in the 60s about this and setting up the laws of robotics, which we still talk about, pretty much 60 years later.
Yeah.
So yeah, I like thinking about how some of the stuff that was written back then has influenced the people who are my age. God, wouldn't it be cool if that really, happened? And, here we are. And, a lot of that is true. And as we go on to think about the direction in my crystal ball, which is, digital USB-C crystal ball that we've powered up for the day, it'll be no surprise that digital is fundamental to that.
Yeah.
So if I had some of the robots from Foundation here today, they're going to be saying pretty much similar things as I think you're going to be hearing over the next few years from your digital care provider.
Sure.
What a segue, hey, look at that.
I know, you teed it up perfectly. So in your current role, maybe talk to me a little bit about your vision for what it could look like, based on the overarching mission of the NHS and, your kind of fundamental desire to care for the whole human, and maybe, what you're seeing coming down as some of the initiatives, if we want to talk about the 10-year plan or the integrated neighborhood teams, just, riff with me for.
Yeah, we'll dig. Before we do that, can we go back to some first principles?
Please.
And the first principles are, we can do more now than we ever could before. We know more than we ever could before. That our population is aging, and a lot of it in ill health towards the end. And so their needs are increasing.
Right.
Because our birth rate's dropping, the number of kind of people that there are to deal with that is dropping.
Yes.
Our economy is not kind of skyrocketing at the moment. So the amount of money and resource there is to deal with that is kind of flatlining or, going up or down, but it's not as if we've got a large amount to invest in this.
And how do you how do you guys see enrollment in medical school here in the UK?
How do we,
or rather, what are the rates at which? Because in the state, because you mentioned all of those things.
Yeah,
all of those things are true in the United States.
Yeah.
We also see in the US that students are enrolling to be GPs or primary care physicians less and less. Still specialty care, some, but with the expenses of medical school and everything else, like it's a real concern from a and then you also have the baby boomers in the US retiring, and not as many folks backfilling those positions. So anything.
Yeah, well, it costs a huge amount to train a doctor.
Right.
So there's a limited number of places there. Actually, family medicine or general practice, quite a lot of people want to do. The thing is, when they then go ahead and do it, they don't want to work full time, or some people have come from abroad and they want to go back. So it's difficult then often to train enough people and for them to work enough and to work enough in this country.
Right.
So
Got it. Okay. That's helpful.
it's complex. And that all kind of comes down to the fact that, workforce is a fundamental part of what we do, but it is simply not sufficient to meet the challenges that we have.
Agreed.
And therefore, digital has to be a lot of that solution. So I talk about clinical debt. And what I mean by that is we know that there's a lot of people who are not being treated optimally for their conditions. And it's not like we just know it in the sense of we feel it. We gather all that data. We look at it. It's nationally available. You can just go online now and have a look.
Mm-hmm.
And the answer to how do we deal with that has historically been, well, we'll incentivize people more, or we'll put more teams in to do that. And yeah, it works a little bit in some places, and that's great. It worked over there because they did this clever thing, and over there because they put in a team. But we are not interested in just solving it in a part of the world, because what that does is it creates inequalities. We need to solve this at a national level, and I'd go beyond it. You just talked about the States. We need to solve it at an international level. Yeah. If I have high blood pressure here in York, and you've got high blood pressure in New York, it's the same. It's the same sort of treatments that we want.
Right.
And so, dealing with that clinical debt using AI, using chatbots. I think in the States, through Congress, you're getting a motion at the moment so that AIs can be the end of prescribing as well, so that you can have that circular loop, not just not human in the loop, but human over the loop.
Right.
A lot of people are talking about human in the loop. The problem with that is that the human in the loop gets all the work a lot quicker.
Right.
And that becomes overwhelming. You could deal with, millions of people at exactly the same time if you've crafted that algorithm. So kind of the long and short of it, therefore, is if we carry on without a really heavy digital arm, there's an existential threat to what we can actually do. The rich will get their care. The poor won't. You will get inequalities, all sorts of problems. If we can mitigate that and free up our human brains for the uncertainties that I'm not sure what's going on, but we get all the protocolized medicine. If you've got blood pressure, there's only a few things you can do.
Right.
If your cholesterol's high, there's only a few things you can do. So that's perfect for chatbots and AIs to do. If you're feeling, just don't feel right, and I haven't felt right for a while, you probably need to talk to me, and we need to kind of work out between us the best way to go. So I see a lot of people trying to put AI into that front end to triage. And I think that's okay, but that's the really risky end.
Right.
I'd love to see a lot more dealing with that clinical debt and freeing up. That's to do with prevention and stopping people get unwell.
Yeah.
So that's my crystal ball.
Yeah. No, I think there does tend to be a lack of emphasis on a lot of the more downstream use cases for AI and automation. So that tracks. And I haven't given enough thought to the chasm that AI can and is potentially creating in inequality in care.
Yeah.
It's now that you've brought it up, I can't unsee it. And I suppose I've seen it here and there before, but the more that I think about it, right, and clearly here in some instances, and then thinking about a capitalist, country like the United States, that's a very real threat. What do you see here in the UK and in the NHS as some of the biggest challenges to achieving, that future state?
So historically, what we have done is kind of identify a need and you kind of test the market. You go out to the market and, maybe you get a product and then you kind of oversee it and look at it. And that's kind of really quite slow, that whole process. I was in a study looking at a particular form of AI and I said, so when are we going to report on this? They said, oh, it's in 3 years' time. I said, in 3 years' time, it'll report on itself.
Yeah.
I mean, we're moving so rapidly. So I think we talk a lot about wanting to increase our risk appetite and sort of push those boundaries.
Yeah.
But, society as a whole just tends to move a little bit slower than that. And so we're just, the challenge is to move fast enough to keep at that cutting edge of tech, to be able to really, really challenge that. And I think that a lot of this, if we leave it to the market, we're going to struggle to get that national coverage, get those inequalities out of the way, because the buying power is all fragmented. For me, I would love to see this is national infrastructure.
Right.
So this is the best of the NHS, the best of government, working with the best of the private sector in a collaborative way to generate something. I was seeing my Canadian friends just recently, and talking to them about how could we collaborate? How could we do something? The middle power countries. We have the possibility of not just doing this for ourselves, but really having a moonshot, because what we're having is the same as you, is the same as everywhere.
I've been really impressed with some of the things Australia has done too.
Absolutely. They've got a great AVT thing that's come out of there, for example.
Yeah.
They've done some good front end stuff. So yeah, and chatting with other companies that have been international, I think it's real good learnings for everyone. And the fact that, you're from New York and I'm from England and we're sitting here having this conversation,
yeah,
we've got that as well.
Right.
So I think in a way it's almost too big for one country to really nail. And if we could collaborate at scale.
Yeah.
So here's our pipe dream.
Yeah. And especially because if you get down to the root of the, issue is the wrong word, but like you were saying before about high blood pressure or this or that, I mean, that's what we're up against. And we're up against the health of these humans. Now, the constructs of the systems themselves are different, but the goal that we're looking to reach is the same.
Yeah, that's right. And humans are the same, and a lot of the medicine is the same.
Right.
And so it's not rocket science. If you're taking the front end where it's really vague, there's a lot of cultural kind of things about that and working out what someone really means and what are their expectations. That's tricky. And I think a lot of that might need to be much more sort of nationally nuanced. And the national direction is to have a chat conversation at the front end of your NHS app.
Right.
But, that back end is, I think, standardized. If you need to lose weight, motivational interviewing, various medications that are available. It's pretty similar, and we could be collaborating on that. And as soon as you get it, if it's in collaboration with a country and you've got IP, so I feel there's a moonshot for us there to do.
Yeah.
So we're thinking big on the podcast today.
I love it. Are you optimistic?
Yeah, I am, because healthcare breaks a country. The cost of healthcare is just so vast and keeps going up and up and up.
Yes.
That we either do it or we're existentially lost.
Right.
So I am optimistic that there'll be enough brains around, and the amount of money that you can save. So if you control someone's blood pressure, you reduce the risk of them going to hospital in 6 weeks' time. This is big stuff.
Yeah.
So I think as soon as we really apply if we get the right focus around that, I am optimistic that we can do it.
That is my concern though with the United States is, we as a healthcare conglomerate make more money when people are unwell than when they're well. And I know, we are seeing slowly but slowly more shifts to, payment for keeping people well, but not fast enough.
So you must correct my misunderstandings of the US system here. But of course, when you're unwell, the hospital makes money and the doctor makes money.
Right.
The insurer's paying for that.
Right.
So the insurer is the one that has every want to keep that person well. And so in some ways, you need to step outside of the deliverers of the healthcare itself in order to be able to deliver something kind of that's overarching, that doesn't depend on the doctors to do stuff. And that's the same in this country as well, to a degree,
Yes.
that our healthcare is very fragmented. So in a surgery in my town, I do one thing. There's a surgery 100 yards down the road, they do something else.
Mm-hmm.
And I might focus on one thing and they focus on another thing.
Yeah.
And that brings inequalities. But if you can put an overall wrapper around, so you've got a conversation, NHS, Annie, or whoever it is on the front end, who's able to offer advice and support and direction above the level of the surgery, you actually get a level of, hey, nationality. You get a national health service. So we don't have a national health service, really. Spoiler, it's a fragmented sickness kind of service, sometimes a service, sometimes not. To be truly national, having this kind of setup above the small organizations, and likewise in the States, setting an insurer going, yeah, great, you want to insure with us? Look what we've got in the back end. This is going to keep you well. This is a chatbot. You can do this. And that blurring maybe of the insurer-deliverer boundary, where an insurer is also being able to fill a prescription for preventative stuff.
Yeah.
Could, you have a preventative arm that's an insurer, and then you have when it goes wrong, you have the other people who pick up the pieces that the insurer pays for.
Yeah.
I can see that working.
I don't know why I just thought of the federated data platform.
Oh, yeah, there you go. So data is oil.
Right.
It's a modern oil.
Yeah.
So how you get data together to really find these people, and I don't know how it works in the States, but over here, that's a big question. There's a lot of legacy laws around data controllership, data protection,
Sure.
and how you help with that. So yeah, should we riff on that for a moment? Hey, okay. So I'm a GP.
Mm-hmm.
I am personally liable, which means because I hold the business and I own the business with my partners, we are personally liable for what happens with that data. And that makes people really scared because the fines potentially are like multiplications of your turnover, which is like millions. So it can bankrupt me.
Right.
And so those laws were not really, when they were designed, it wasn't kind of set in people's mind maybe that we'd want to be working with data in the way that we are. So there are lots of ways in which that data is shared to support people's health and research. I think the key thing, if we can really get all that together, is being able to map a lot of these things to be able to prioritize cohorts and do it maybe above where the doctors are, so that nobody's left behind.
Right.
But also, how do you as a patient, as a citizen, get your own data? So you can get your banking app,
Right.
you can get all your financial data, your financial health, have different plans, you can upload it wherever you want. You can't do that with health data here in this country.
Yeah. No.
So
I was just going to say, and you can't really in the US either.
oh, right.
Yeah. And we don't have a federated data.
But it's all potential. So half the people on the NHS app can see their data, but it's only half because the GPs feel a bit nervous about sharing the data.
Right.
So there's some ways that we need to help people to share that data. And of course, AI, LLMs are perfect.
Yeah.
They can look at all the data and go, that's sensitive, that isn't.
Right.
But we're not helping people to share data. as soon as we've got all of that flowing, wow, this country has, we are the oil rich, we're the data rich nation. And the things that could come out through the research, and because our primary care records are, probably the most detailed in the world.
Yeah.
And so if we can get a lot of that working and people can then look at their data and manage it, I think we've got a rosy future, but we need to help that to be unlocked. And I think, again, the solution to that is someone getting a smart AI that will help the controllers to know that they're sharing the right stuff.
Right. And do you think patients are apt to own their own data?
Oh, yeah. The number of times I get, because I share as a doctor, people are looking at it, they're curious about it, they're going, oh, what's happened with this test result and the other test result?
Right.
So, yeah, I think people really are keen to do their data. When my son was sick, he didn't ask me what was wrong. He went to ChatGPT. And if there was some way of ChatGPT or some sort of AI knowing his medical history, it could have given him maybe different ways of looking at it. Yeah. So we're not there today,
right,
because of the clinical risk and all the rest of it, but it's not long. People are going to be clamoring for their data.
Agreed. I mean, we're not far off from AGI, and so, I mean, it is I am optimistic as well.
Yeah.
Yeah.
Excellent.
Great way to end the episode. And I do have one final question, Tim, which is, if you could go back 5, 10, even 20 years in time, what advice would you give your younger self?
Oh, okay. I think there is something about the being true to yourself, which was important.
Mm-hmm.
And just sort of going beyond that is be true to yourself and don't give too much.
Mm-hmm.
So there's kind of a paradox there. I think when I was younger, it's all about just giving until I was like, oh, I've got nothing, and I'm just being exhausted.
Yeah.
And I think as healthcare teams, we put ourselves sometimes like lower down,
right,
that pecking order. And so, yeah, Tim, it's okay to stop.
Yeah.
It's okay to stop.
Yeah. It is crucial. I have to keep, I can't pour from an empty cup.
Yeah, you got it.
Tim, this was amazing.
Just great to be here.
Yeah, thank you so much for taking the time.
Pleasure.
And to our listeners, thank you for tuning in, and we will catch you all next week.